In part 2 of this talk, I will give you some examples. The first example is an infarct on the inferior wall of the heart. This is usually caused by an occlusion in the right coronary artery, but can be an occlusion in the left circumflex artery, which then comes around from behind. We see this in leads 2, 3, and AVF. Looking at 2, 3, and AVF, we can see a STEMI occurring in all three of those leads. And remember, these are the inferior leads. Therefore, the superior leads, 1 and AVL, should show reciprocal depressions. Whenever you see an inferior STEMI, you should assume right heart involvement. And in this example, I was struck by what's happening right here. V1 is the only chest electrode located to the right of the sternum. Seeing a STEMI in V1 should further give you suspicion that right heart is involved. Now let's look at a septal infarct. An occlusion in the left anterior descending artery can cause a septal infarct. We would see that in chest leads V1 and V2. Well, there they are, V1 STEMI. A little bit maybe have extended into V3, but nothing in 4, 5, and 6. Also notice that there are no reciprocal depressions. The reason is a reciprocal depression should show up on the posterior electrodes, which are not being recorded. Now we're looking at an anterior infarct, also produced by an occlusion of the left anterior descending artery. We see this usually in V2, V3, and V4. There we can see it, V2, V3, and V4, anterior. We're not seeing it in V1. If the infarct were more centered, we might see it picked up in V1. This infarct is probably a little bit more laterally because we're beginning to see a little bit of lateral involvement here in V5. Also, we see in 1 and AVL an ST elevation, also indicating some lateral wall involvement. Once again, we don't see a reciprocal depression because that reciprocal depression should appear on the posterior electrodes. This is a lateral wall infarct, which is caused either by the left circumflex artery, which comes around here, or by this diagonal branch of the left anterior descending artery. We see that in the superior leads, 1 and AVL. Remember, they're up here in the shoulder. Also in V5 and V6. We can see now V5, a little bit in V6, 1 in AVL. So this is a lateral infarct. We do see a little bit of anterior involvement here in V4 especially. Because 1 and AVL are superior leads, we would expect to see reciprocal depressions in 2, 3, and AVF. And we do. This appears to be a high lateral STEMI. By that I mean high up on the lateral wall, sometimes referred to as a basolateral STEMI, because the basal surface of the ventricles is the upper part just below the atria. So we can call them high lateral or basolateral. And we see it more in the superior leads than we do in 5 and 6, again indicating this is a high lateral STEMI. If we put these all together, we see the inferior region, anterior region, and the lateral region, and I've left off the septal region, which would come in approximately here. Let me put the Einthoven triangle with the augmented leads on top. The superior leads, located on the left shoulder or left arm, 1 and AVL, the positive electrodes of these superior leads are looking at the lateral surface. The inferior wall of the ventricles is pointing toward the inferior leads, 2, 3, and AVF. Looking at the chest leads, we can see that V5 and V6 are facing the lateral wall, V2, 3, and 4 are facing the anterior wall, and if I put the septum in here, V1 and V2, the septum. One way to picture this is to create blocks on a standard 12-lead electrocardiogram with 1, 2, and 3 on the far left and V4, 5, and 6 on the far right. So we refer to these as the inferior leads. A STEMI in the inferior leads would be caused by the right coronary artery. The superior, especially the lateral superior leads, are 1 in AVL. Leads V5 and V6 are also lateral, and a STEMI in this region could be the result of a blockage in the left circumflex artery or an occlusion of that diagonal branch of the LAD. And the anterior septal region is V1, 2, 3, and 4. I will leave with this diagram a little table here showing where the STEMIs are seen. Septal, anterior, or anterior septal STEMIs will be in V1, 2, 3, 4, and we don't see a reciprocal depression. In the lateral STEMI, we would see a reciprocal depression in 2, 3, and AVF. And the same with an anterolateral STEMI. 1 and AVL will show their reciprocals in 2, 3, and AVF. An inferior STEMI in 2, 3, and AVF show up as a reciprocal depression in 1 and AVL. We don't normally see a STEMI in the posterior leads unless we place them on the back. So all we're going to see with a posterior STEMI is a reciprocal depression in V1, 2, 3, and 4. One wants to be a little bit careful here because it might be mistaken for an end STEMI. That is, an infarct producing an end STEMI. However, if we were to put posterior leads V7, 8, and 9, we would likely see a reciprocal depression in the anterior leads. And if we see reciprocal depressions in the anterior leads, we would expect to see a STEMI in the posterior leads. That concludes part 2 of this talk on ischemia.